No problem. Thank you for having me this afternoon. Thank you everyone for joining. I hope everyone's well. My name is Kayla. I'm one of the specialist biomedical scientists in microbiology at Maidstone Hospital. I'm just going to be giving a presentation on parvovirus, the epidemiology, and what we do from a lab point of view as well. So, parvovirus is derived from the Latin word parvum, which means one of the smallest DNA viruses. It belongs to the Parvoviridae family. And in terms of clinical importance, it's a significant cause of erythema infectiosum, also known as slap cheek or foot disease, as well as aplastic crisis and fetal hydrops. In terms from a lab point of view, diagnosis is really important, and it's important that we focus on accurate and timely lab diagnosis in order to guide clinical management. In the UK, we have been seeing increasing level of parvovirus B19 activity, and this is just a graph showing the monthly laboratory confirmed reports of parvovirus infection in women, because parvovirus in some pregnant women can lead to serious health problems for the fetus. And this is between January 2017 and June 2024. So what we can see is we've had some very low activity since 2018, and then the cases started to increase again at the end of 2023, beginning of 2024. And these levels that we're seeing now in May has surpassed the levels that's seen in the previous 2017-2018 peak on the left there. So it's evident that we are in another outbreak of parvovirus within our communities. These are the cases within MTW Trust as well. So we can see that there is similar trends in terms of the MTW cases of parvovirus here compared to the slideshow before. With this graph, it demonstrates similar patterns there. What we know about parvovirus is that it exhibits seasonal patterns. So we see increased cases during the late winter, the spring and the early summer, which tends to align with school cycles. So we know that the virus is transmitted via respiratory droplets. So during the later winter months, there is a closer proximity with children, and as well as children being more common to spread the virus within these school settings. We also know that parvovirus exhibits cyclic outbreaks. And what I mean by that is cyclic outbreaks every 3 to 4 years. What happens is after an outbreak, a significant proportion of the population will gain immunity, which leads to a temporary decline in cases. What we kind of saw back here, the population gains immunity and then the cases rapidly decline. And then what happens is as more and more non-immune individuals accumulate over time, another outbreak occurs. Also, temperature and humidity can play a factor in the sense that viruses, they tend to spread through respiratory droplets, and they thrive in these conditions of cooler temperatures. So in these winter months in the early spring, this could contribute to the seasonality of the virus. So in the lab, we will look for certain clinical details to provide us with some sort of indication for testing of parvovirus. And what we'll look for is patients that have unexplained anemia or aplastic crisis, where the bone marrow stops making red blood cells, particularly in patients with certain hemolytic blood disorders like sickle cell or thalassemia. Also, pregnant women that either has been exposed or has symptoms that are suggestive of parvovirus 19. Fetal hydrops as well, where there's a large amount of fluid building up in the baby's tissues or organs that causes swelling, or any other signs of fetal distress. Immunocompromised patients with an unexplained fever or cytopenia will also raise indications for testing in the laboratory as well. Diagnostic testing is extremely important because we want to be able to provide an accurate diagnosis of the infection, because sometimes parvovirus can also present with symptoms that are similar to other conditions such as rashes, joints, joint pain or anemia. So diagnostic testing helps us to confirm whether these symptoms are due to parvovirus or due to another cause. Early symptoms of parvo can also resemble those of other viral infections like rubella or measles. So it's really important that we identify the specific virus responsible for the infection. Management of complications in vulnerable patients as well. Parvo can cause complications in vulnerable communities. And for one example, parvovirus can cross the placenta in pregnant women and infect the fetus, which could potentially lead to severe complications in pregnancy. Also, immunocompromised individuals, they have a weakened immune system and they might not be able to clear the virus effectively, which could lead to a chronic and persistent infection. Through diagnostic testing in the lab, we're able to help identify and treat any persistent and chronic infections. And in cases where there is a chronic infection and it's a concern, such as immunocompromised patient, ongoing diagnostic testing can help to monitor the viral loads and guide long-term management for that patient as well. We're also able to provide confirmation of an individual's immunity. So through serological testing, we can determine whether a person has immunity to the virus, either whether that's from a past infection or exposure to the virus. As we know, parvovirus can cause outbreaks, typically every 3 to 4 years in that cyclic pattern, particularly in schools and daycares and nurseries. So identifying these cases through our testing will allow for a better management of outbreaks, control outbreaks, and reduce the spread of the virus. So in our lab in microbiology at Maidstone, we do something called a torch screen, which is a group of blood tests that test for various infections in pregnancy and also sometimes in infants as well. So it stands for Toxoplasma, other viruses that include parvovirus, VZV and syphilis, rubella, cytomegalovirus, and herpes simplex virus. Torch screening is usually done in the early pregnancy of mum, and also in infants where there's any concerns of congenital infections, especially if we know that there has been a known exposure. So how it works is we would take a current blood sample from the mother, and as well as her booking blood, the blood that she's provided to us at the time of her booking her pregnancy in, and we will test the mother for presence of IgM and IgG antibodies, which I will go on to explain later on as well. On the right-hand side here is just an example of one of the reference forms that we fill out, and we refer it to East Kent to do the torch screens. And that will include parvovirus, IgM and IgG antibodies, as well as rubella. So in terms of serological testing, we don't actually do any of the testing in-house at Maidstone. We don't have the facility to do parvovirus testing here. So what we do is we send it to Ashford at East Kent, and they have a machine called a liaison, which is a chemiluminescent technology where specific antigens will capture antibody in that blood sample. So what the liaison will do, it will test for IgM and IgG antibodies of parvovirus. IgM antibodies are going to detect a recent or an active infection. These antibodies tend to come about within 7 to 10 days, and a positive result indicates a recent or an ongoing infection, and a negative is no recent infection. IgG antibodies, however, will indicate a past infection or immunity, whether that's through exposure. And these antibodies tend to arise about 2 to 3, a couple of weeks after being exposed to the virus. And if the individual is positive for IgG antibodies, they have a past infection. This is also another example of a reference lab report that has come back from East Kent that tells us the IgM and the IgG antibody results. So in this specific patient, they both had IgG and IgM antibodies. And then as a confirmation, East Kent will then send that to another reference laboratory called micropathology, where they will do parvovirus PCR testing, which I'll also explain shortly. So this is just a summary of the different combinations of antibodies that you can get when we are testing for parvovirus. So we can get a combination of IgG and IgM antibodies, positive IgM antibodies and negative IgG antibodies. Is going to indicate an acute or a recent infection. If we're positive for both types of antibodies, it can also mean it's an acute infection, but it tends to be more at a later stage because IgG antibodies can also develop whilst IgM antibodies are present. If we don't have any IgM antibodies, but we have IgG antibodies, this is indicative of a past infection or immunity through exposure. And if no antibodies are found in the patient's serum, there's no current or past infection, and therefore this patient is susceptible to contracting parvovirus. Molecular testing is done by micropathology. East Kent will refer our samples on our behalf to them, and this is a Parvovirus B19 DNA PCR, and this is very useful for monitoring viral loads and detecting and quantifying viral DNA, especially in immunocompromised patients who have those persistent and chronic infections of parvovirus, and when in these communities there can be a lack of antibody response. And these types of patients, they don't produce sufficient antibodies, which could end up leading to false and negative results. So PCR is really the only reliable option when it comes to that. Also, through PCR testing, we're able to detect any early infections, because what can happen is the immune system, before the immune system has produced any sort of detectable levels of antibodies, whether that is IgG or IgM, it's with the PCR detects much smaller volumes of DNA. So we're able to pick up infections from an earlier stage. So this is really useful for the initial stages of infection. Serological testing relies on the detection of antibodies, which can take time to develop after infection. But IgM antibodies can take up to 3 weeks to appear after you've been exposed to a virus. So if we're doing serological testing, we could miss that 3-week period where we're waiting for the IgM antibodies to appear. Also, we can clarify any ambiguous cases where both the IgM and IgG is negative, but the clinical suspicion remains quite high. Serological tests can yield inconclusive results, particularly in cases where the antibody levels are quite borderline, or if the testing is done too early in the infection process. There can be some cross-reactivity that occurs between parvovirus and rubella, and it's a recognized phenomenon in serological testing. So as a lab, it's really important we are aware of this phenomenon. So what can happen is cross-reactivity can lead to false positive results and misdiagnosis. The antibodies that are produced by the immune system in response to the virus might non-specifically bind to antigens used in the test for another virus. So, for example, a patient that has a recent parvovirus infection might have antibodies that cross-react with the antigens in, for example, a rubella test, which will lead to an incorrect diagnosis of a rubella infection. And this happens because these two viruses, parvovirus and rubella, they share similar epitopes, which is a specific part on an antigen that is recognized by the antibody. And if these and the serological tests that we do are designed to detect antibodies against specific viral antigens, but if the antigens that we're not using, if they're not highly specific, they might also bind to antibodies to similar antigens from other viruses. So the need for confirmatory testing, i.e. through PCR, the DNA PCR, is really important because this is going to help to reduce the risk of this cross-reactivity phenomenon from happening. As a summary, serological, whether IgM and IgG, and molecular tests are all essential for diagnosing parvovirus B19. Molecular is a lot more sensitive, and the accurate diagnosis will help to manage and mitigate any complications, especially in our vulnerable populations, our pregnant patients, our immunocompromised patients. And it's really important that we understand the difference between IgG and IgM antibodies when determining the stage of infection. And those populations of people, pregnant women, immunocompromised individuals, and those with blood disorders like sickle cell, they require a lot more special attention because the virus can lead to more severe outcomes in these populations. Thank you very much, everyone.
Great. Thank you, Kayla. Kayla, that was really interesting. So I'll just open up for anybody who's got any questions for Kayla. Thank you. I've got a couple of questions. So my first one, so how long do the IgG antibodies last in humans? So if I had this condition when I was a child, would I still be resistant now?
You will have IgG antibodies for life.
Ah, yeah. Wow. Okay.
So that will provide you with a long life immunity.
Yeah, sure. Okay. And the other things I was thinking of, so the numbers look quite small compared to, say, influenza, which is quite a serious illness. Is that so? I was just looking at your MTW numbers there. I think you had about 40 or 50 people. Is that right? And is that inpatients in the hospital, or would that be people that have come through your outpatients?
I would have to confirm with you on that. I'm not 100% sure on whether that's inpatient and outpatients combined.
Okay. Thank you. I'm just wondering what the severity is, because obviously influenza is and COVID, for example, they're very serious conditions, aren't they? And they affect quite a lot of people. I'm just trying to get a scale of this. Is this something that's quite serious in terms of health outcomes, but not many people get it, or is it up there with the kind of flus and COVIDs?
It's quite out there, especially now. We are experiencing another cyclic outbreak of it, so the cases are significantly rising in terms of laboratory confirmed reports, as I showed you on the screen. In terms of the specific numbers compared to influenza and COVID, I'm not 100% sure, but it is quite a significant cause of concern because of the implications that it can produce in vulnerable patients, in pregnant women, and in immunocompromised patients as well.
Yes, thank you. And that's really interesting. I could see you're directing your programs to those groups, aren't you? As you say, pregnant women and the infants the suspicions of illness. And the last thing I picked up. So, given that your DNA test was more sensitive than the serum tests, why do you not do that on every patient? Is it to do with cost, or?
Well, what it is, when we do the serological testing, it's going to tell us the IgG and IgM. It's going to tell us whether it's a past infection or whether it's been acquired acutely more recently, whether the pregnant woman, whether mum has contracted this within her pregnancy, or whether it's something that she's acquired newly.
Oh, fantastic. So it's additional information then. If you just did the DNA test, you wouldn't have that information. That's what you're saying.
We also want to know the IgG and the IgM in order to determine the stage of the infection as well.
Yes. Great, and actually your slides explain that very well. I just
Yeah,
putting the two and two together there.
yeah.
Thanks for making the links for us.
Thank
Great,
you.
thank you, Kayla. Anybody else have questions for Kayla? Okay, well, thank you very much.
Thank
I'll
you.
stop the recording now.
Okay, thank you. Thanks, everyone.